Dr. Noha?
You hear me now?
Yes, yes, we are.
Yeah. Bismillah.
Start, please.
Good evening. It gives me a great pleasure to be here with you in this evening. Thank you very much for your kind invitation to share you this great meeting. Thank you, Dr. Muhammad, for your invitation. My talk today is about the treatments of cataracts in eyes with glaucoma. Yeah, cataract surgery in presence of glaucoma poses challenges need to be addressed to offer maximum benefits without complications. Several facts that the cataract and the glaucoma happen together in old ages, and more frequently, the patient who had cataract or the patient who had glaucoma had cataract as well. The cataract may affect our ability to test the stages of glaucoma, affect the visual field and the OCT accuracy, and also make a generalized depression. And the glaucoma surgery may cause cataract, and the cataract surgery may increase the IOP and develop glaucoma. So there are interrelated disease. First, we have to make sure that there is glaucoma. It's important for the cataract surgeon to realize that the glaucoma is not just an IOP problem. All of us check the IOP, but it's important to employ the visual field and the OCT, particularly important in a glaucoma patient. And also, we have to look at the fundus, at the details in the fundus. Maybe by routine cataract, we discover the branch retinal vein occlusion with advanced glaucoma. Also, we have to do gonioscopy, especially in the glaucoma patient, if I decided to do mixed procedures. Our goals are to prevent the post-operative IOP spikes, to achieve long-term IOP control, and to rapid visual rehabilitations, to minimize surgical trauma and the risk. And for the trauma, not from the surgery, the risk of the surgery. Also, there is psychological trauma. The patient who go to the operating room twice is not like the patient who go once. And also, we need to reduce the cost. Go to the insurance company several times or to the medical care center several times. There are several therapeutic options. First, we can do phaco alone and wait. We can do laser first and later on do phaco. We can do trap or filtering surgery, then do phaco, and we can do combined surgery. The deciding factors, it depends on several factors. Is the patient has proper IOP control in his current medications? Is he reaching to the target IOP? And how many drugs did he use to achieve this target IOP? Did he compliance or tolerance to the treatment? What the type of glaucoma? Is it open angle glaucoma or angle closer glaucoma? And what the stage of the glaucoma, severe or early? Also, we have to look to the social and economic status. That if the patient have money to access to the medical care or depends on the insurance companies, and how much this disease and this treatment affects his quality of life. The first option is to do cataract alone. A glaucoma patient wants to off their drops. Several studies show the value of cataract surgery in getting pressure down. But there is some cavities. It's not a cure, but an incremental improvement, but it's good opportunity to clear the slate and stop the drops to determine what is truly working. Many patients refer to me with 3 or 4 drops, and these drops do nothing. We have to, or this good chance, the cataract surgery to stop these drops and see which one really works. IOP reduction is greatest in patients with ocular hypertension, early glaucoma, and narrow to close angle. Cataract surgery may be creative in narrow or close angle glaucoma. The level of the IOP lowering after cataract is due to the widening of the angle and the lens vault. Gonioscopy and OCT angle show us the iris and the lens vault. But unfortunately, it's not very effective in chronic angle closer glaucoma. Also, in cataract surgery, we're expanding the rule of the mix. The mix procedures last 3 years improved the eye stent indicated in the open angle glaucoma. Maybe we have to put more than one to achieve good results. CyPass supraciliary also indicated in the open angle glaucoma and may have a rule in close or narrow angle glaucoma. Also, XEN subconjunctival devices common lately. Cahook dual blade, peeling off the trabeculum and the Schlimm canal, also indicated in open angle glaucoma, may have a rule in narrow angle glaucoma. We learn a lot from the mixed trials, but the most important things that we learn that the cataract extraction is the best mix for several reasons, but the important is that all options after doing the cataract surgery remains for future interventions. The second option to do laser followed by cataract. This is to reduce the need of perioperative glaucoma medication and to reduce the perioperative IOP spikes. We do ALT, most of the time we do SLT, and nowadays we do MLT, micropulse laser trabeculoplasty. Then we do phaco. Filtering surgery, the third option, filtering surgery followed by cataracts. If glaucoma is uncontrolled in spite of maximum tolerable medical therapy, very advanced glaucoma requiring a very low target IOP, we no need to do cataract, we need to lower the target IOP. Secondary glaucoma associated with uveitis or neovascularization because we want to deal with one problem at a time. Otherwise, we go to combined surgery. It depends on if, in spite of maximum tolerable medical treatment and or laser trabeculoplasty, glaucoma control is poor and patient is intolerant or incompliant, patient cannot afford long-term medical treatment because you know that the eye drops and the medical drugs expensive nowadays. Patient with advanced glaucomatous damage and cannot tolerate post-operative IOP spikes, because the patient with advanced glaucoma, we don't want with CD ratio 0.9. We don't want to convert him to CD ratio 1.0. Uncontrolled glaucoma with mature cataract, we need urgent visual, rapid visual rehabilitations. There are several types of combined surgery. The old-fashioned ECC with trabeculectomy, small incision cataract surgery with the trap, and phaco with filtering surgery, either trap or non-penetrating. Also ECP, endolaser cyclophotocoagulation after doing cataract, and use tube Ahmed valve also, and also use micro-incision glaucoma surgery with cataract surgery. I want now just to show you an example for the patient. I did combined surgery to him 2 weeks ago. First, we fashioned the the trap, the scleral flap. Don't enter to the anterior chamber. Go back to do the phaco. You can also sure put betomycin. When you finished your regular phaco, finished complete the phaco, then go back to your filtering surgery, your trap. I do trabeculectomy and do iridectomy, then finished my filtering surgery. The same role when we want to use, when we want to do deep sclerectomy. You have to do first the superficial flap. Don't do the deep flap. Shift to do the phaco and then return to complete the deep sclerectomy to avoid the making puncture from the increasing irrigation during doing phaco. The same rule for the tube. You have to fix the plate of the tube and then don't enter that tube in the anterior chamber. Do the phaco, then enter the tube in the anterior chamber. What are the disadvantages of the combined procedures? Reduce long time success. You know that time success for the trabeculectomy with combined surgery less than the time success when we do it separately. Increase incidence of post-operatively inflammation. We have to avoid it in certain cases: secondary glaucoma, scarring in the conjunctiva, normal tension glaucoma, and advanced cupping. Is there any advantages? Yeah, one benefit: cheap. Buy one, get one free. We have to take care of some considerations. First, glaucoma patient want to see. We have to maximize refractive correction, correcting astigmatism keratotomy. Toric are excellent for glaucoma patients. Glaucoma patients benefit from the toric lenses As much as any patient, though pseudo-exfoliation patient may be at risk. A true accommodative IOP would be idle. Multifocal IOLs should be avoided because it impairs the visual field detection. Monovision is required. Avoid complications. Glaucoma patients are more likely to have pupil problems. Small pupil with poor visualization result in capsular tears and other complications. So here the key is don't be a hero managing the pupil by drugs, epinephrine to extend it, or by devices stretching like Mauricking ring or iris hooks, managing the zonula in pseudo-exfoliation patients, and managing medications to avoid CME. Expect IOP rise post-operatively. Glaucoma patient more likely to have post-operative IOP rise. Some surgeons use Diamox as a prophylactic Diamox or use meiotic intraoperatively. The reason for the IOP rise is not from using the steroid, because steroid-induced glaucoma require 2 to 4 weeks to rise the IOP. So it's most likely the reason it's usually from the viscoelastic. Approach to glaucoma medication post-operatively, it's good chance to clear the slate and start all over again. Any questions? And thank you very much, with all love from Damascus. Thank you.
Thank you. It's our pleasure to have you on this conference. We will see if we have any questions.
Question? Yeah, I'm ready.
Dr. Noha, thank you for your lecture.
Thank you very much for your invitation, and my pleasure.
Thank you. In case of children having cataract and glaucoma, and the glaucoma is controlled with drops, you go for cataract and then monitor the glaucoma, or you can go combined surgery?
For the children, only when there is a young age, we have to direct to the surgical treatment. So if you have cataract also, we want to go for combined surgery. But maybe if the cataract is not very affected, you can do filtering surgery before, then later do phaco or cataract surgery.
What types of children that you can use the minimal invasive glaucoma surgeries? Which type of?
Of the filtering surgery for the congenital glaucoma, you mean?
In minimally invasive, you can go for children and do minimal invasive.
Yeah.
Is it a higher success rate in children?
No, for me, in my experience, I do non-penetrating for the primary congenital glaucoma, and give me very good results, because if you want to use non-penetrating surgery, you have to apply it indicated in version Schlemm canal to take a good result. And version Schlemm canal, we see it in founded in the congenital glaucoma, in primary congenital glaucoma. So non-penetrating gives me very good results in congenital glaucoma.
Thank you.
Thank you.
No more questions. Thank you. Thank you, Dr. Noha.
Thank you very much. Thank you for you, and it's my pleasure.
our pleasure. الآن الدكتور إبراهيم الأستاذ الدكتور إبراهيم الحمدي. The lecture is about glaucoma misdiagnosis.
الله الرحمن الرحيم.
هلا هدول عملوا لي
ايه طبعا في واحد خلص عملية.
ما شاء الله الناس تتغدوا وروحوا. ها في عشاء يا دكتور محفوظ، في عشاء نرجعهم يعني.
وشكله ولا واحد ما اخذ غفوه. انا راكب اشوف له كل